Marijuana, or cannabis, is one of the most widely used illicit psychoactives and has a documented history going back thousands of years. Supposedly, 1 in 3 people have admitted to using cannabis at least once in their life, and 10% of the population use it on a regular basis. Although the most common reason for its use is to experience a mild euphoria and relaxation, others, however, use cannabis to help relieve pain. This reduced pain sensation experienced in cannabis users has been the subject of much study, and the mechanisms of its actions and effects are only just being elucidated. Recent studies are targeting the potential therapeutic advantages that cannabis can offer. These studies are directed at the possible synergism of cannabinoids with analgesic drugs such as opioids, alpha-2 adrenergic receptor agonists, and NSAIDs. Although recent studies highlight the therapeutic uses that cannabis can offer, many other symptoms still remain extant. These include the loss of coordination, inhibitions, anxiety, and paranoia. The symptoms, therapeutically beneficial or not, are a result of the chemical constituent found in cannabis, tetrahydrocannabinol, or THC.
THC is the active chemical constituent in cannabis. It is an exogenous cannabinoid and has the ability to mimic endogenous cannabinoids. The two endogenous cannabinoids in question are anandamide and 2-AG. These cannabinoids are structurally similar. They are all combined to specific cannabinoid receptors 1 and 2 that are dispersed through the central nervous system and the immune tissue respectively. This forms the endocannabinoid system that is responsible for a variety of functions, such as energy intake, metabolism storage, nutrient transport, appetite, and pain. In regards to pain, nociceptors detect pain and travel the signal by specialized peripheral nerves to the spinal cord and the dorsal horn, as you can see here, nociceptors in the dorsal horn. Here it ascends via the spinal thalamic pathway to the thalamus, where they are sorted out and sent to the cortex to be processed. As you can see here, it travels from the nociceptors to the dorsal horn, through the spinal thalamic pathway and makes its way to the thalamus, where it's sorted out, and then it goes to the cortex. And then here, the descending pain modulating pathways are activated. These signals relay the signal to the periaqueductal grey matter, which you see here, which plays a role in analgesia. This, though, is tonically restricted by GABAergic cells, which can restrict the analgesic effect. The endogenous cannabinoids mentioned earlier, as you can see here, and the exogenous cannabinoids, such as THC and cannabis, can inhibit neurotransmitter release from the GABAergic cells. Endogenous cannabinoids are synthesized and released from the postsynaptic cleft within the PAG, especially when they're exposed to noxious stimuli. They then can move to the corresponding cannabinoid receptors on the presynaptic cleft. They activate G proteins. These specific G proteins influence ion flow from the GABAergic cells, resulting in reduction of calcium influx in the synaptic cleft. This ultimately leads to a modulation of pain via an increase in postsynaptic firing. Exogenous cannabinoids such as THC create a greater volume of these cannabinoids that can be used to inhibit the neurotransmitter release within these GABAergic cells. This leads to an increase in the postsynaptic firing of these neurons in the PAG, which produces a more intense state of analgesia experienced by an individual. The potential possibilities that can be extracted from the use of cannabis as a medicine can help patients deal with acute and chronic pain, and can be an excellent future direction for pain management. Such future directions include the possible synergism of cannabinoids with analgesic drugs, such as opioids, alpha-2 adrenergic receptor agonists, and NSAIDs.
Dr. Chahovich's team from the Department of Pharmacology in the Virginia Commonwealth University has implemented scientific experimentations in unveiling possible synergistic interactions between cannabinoids and opioid analgesics. He noticed that the high use of opioids to treat chronic or severe pain were accompanied by undesirable side effects. His study focused on a better analgesic strategy which compromised the use of both opioids and marijuana. The study was conducted on animal models, which showed same level of analgesia when induced to a lower dosage of opioids and marijuana, suggesting synergism does exist. Another study that highlights the possible therapeutic advantages that marijuana can offer is articulated in Xiao Tham and James Angus' study, of the synergistic and additive interactions of cannabinoids and the A2 adrenergic receptor agonists in acute pain models in mice. From these studies, they concluded that due to the similarities between these cannabinoids, opioid, and adrenergic systems, it was likely that one or more of these combinations of selective agonists for each system would interact, and possibly elicit supraadditive or anti-nociception effects. Again, these could provide a more effective judicial selection of dose and receptor-specific agonists that may allow for a better therapeutic window from unwanted side effects. Similarly, NSAIDs are a class of non-steroidal anti-inflammatory drugs that provide an antipyretic and ultimately an analgesic effect. These pharmaceuticals work by inhibiting enzymes such as COX that are responsible for inflammation and more specifically pain. Henceforth, one may surmise that opioids, NSAIDs, and alpha-2 adrenergic receptors work in conjunction with cannabinoids, endogenous or exogenous, in achieving anti-nociception and ultimately analgesia. If exogenous cannabinoids, that is, THC from cannabis, were able to be exploited for medicinal purposes, it could potentially create an analgesic strategy that will have both less side effects and resistance. This would have significant therapeutic benefits to those suffering from acute or chronic pain.